Welcome back to the Dr. Cliff Show. This is part 2 of a 6-part series on the hearing loss treatment journey. Coming up. This episode is sponsored by Natus, formerly Otometrics, the preferred diagnostic equipment supplier of the Dr. Cliff Show. Since the 1950s, Otometrics has been one of the most innovative manufacturers of hearing aid fitting equipment and diagnostic hearing and balance equipment in the industry. When it comes to testing and treating our patients, we only want to work with the best. This is why we use Natus in our clinic. Welcome back to the Dr. Cliff Show. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona, and I am joined with my co-host.
Good morning, everyone. My name is Dr. Rachael Cook. I'm also an audiologist at Applied Hearing Solutions, and we are back for part 2 of our 6-part bonus series with Natus. So exciting. We're covering the patient journey from start to finish. And last episode, we went through assessing the outer ear canal and showed a whole bunch of really cool pictures of different outer ear canal conditions using that Otocam 300. And if you haven't watched that, definitely make sure you go back and watch that episode first, because that's going to lay a lot of the framework for this episode today. Today's episode is going to be covering the middle ear space and its purpose, and also how audiologists assess the middle ear, and specifically how we use it or assess it using the Madsen Zodiac Tympanometer. So definitely make sure that you like and subscribe so that you don't miss any part of this series, because we've got 4 more episodes coming after this.
Absolutely, and they all kind of string together, so it's really nice to watch them in sequential order if you can.
Yeah.
And if you go back to our episode last week, just like Dr. Cook was mentioning, is that we have an episode where we're showing a lot of weird, funky stuff that's going on inside of the ear canal, so you definitely want to go check that out. And some of those conditions that we discussed last week that we looked at with the Otocam 300 from Natus, those images are also going to be in today's video, because we're doing additional testing to figure out potentially what that's going to look like when we do a middle ear assessment with the Madsen Zodiac. So definitely go back and check that video out. But to give you guys some context for today, it's really important that we have an understanding of what the middle ear space is, and in accordance with ear canal and ear anatomy. So I'm going to reference my model here that I have on the desk. And so last week what we were talking about was the pinna, the outer ear, working its way through the ear canal and up to the eardrum. But today we are specifically looking at the structures that are behind the eardrum, called the 3 middle ear bones or ossicles, and the middle ear cavity that they reside in, as well as the eustachian tube. Let's see if I can get my finger on the eustachian tube there. There we go. The eustachian tube right here. Now, you could think of that eustachian tube as the pressure equalizer of the middle ear space. So a lot of you, if you've been flying around in an airplane and your ears won't pop, it's because that eustachian tube is not opening and closing properly to regulate that pressure. Now, we do have a different image that we can put up on the screen here that actually labels these items as well. So there you have the eardrum, which we call the tympanic membrane as the technical term. You have those ossicles, those middle ear bones. You have the malleus, incus, and stapes. There's 3 of them. There's that middle ear cavity or tympanic cavity, and there you can see reference the eustachian tube, and the image does a much better job of lining up with where that eustachian tube is actually at compared to me looking at it on the screen. So let's go ahead and talk a little bit more about those middle ear bones.
Yeah, so you have 3 middle ear bones, and they just happen to be the 3 smallest bones in your body. So we have another picture right there of them on the tip of a finger. They really are that size, and all 3 of those middle ear bones can fit on a dime. So they are super, super small, but they're pretty mighty when it comes to hearing. And so the goal of the bones in the middle ear behind the eardrum, so the eardrum is taking that sound vibration that's coming into the ear, and the eardrum is vibrating to translate that sound over. Well, that vibration travels through the middle ear bones, and it actually acts as an amplifier. And so last episode we were talking about how ear canal resonance adds an additional boost onto sound and gives it some amplification. Well, the middle ear bones also do that as well, to the tune of about 26 decibels of an increase in volume. So really the outer ear space and the middle ear space both have to really be free of pathology, free of obstructions, free of any sort of disorders. Otherwise, sound just does not get all the way into the inner ear correctly.
Yeah, and when you think about what 26 decibels mean, I mean, that is a massive loss of hearing. Huge loss of hearing. And when you have an issue in the middle ear space, to any degree, it can significantly impact the flow of sound through that entire system. And you start compounding that with outer ear issues on top of that, that can just be an absolute mess, to the point where your hearing organ could be working fine, but you're just not getting enough sound to hear at all. And when you go in and see an audiologist, we have to be able to identify, okay, what part in this pathway of sound is broken, so to speak. And I think that that's why using the Madsen Zodiac is so important, because it will actually help us identify where in that chain the breakdown happens at.
Yeah, this is, like you said, that chain, that everything in that chain to hear and hear correctly has got to be in the proper working order. So if the outer ear looks great, that's awesome. But if there's a pathology in the middle ear, that's now blocking that transmission of sound again. So we've got to go step by step by step here. It's exactly what we're doing with this series, is really taking you from the outside ear all the way through the system and kind of talking about the types of things that can go wrong in those systems as well.
And let's talk about some of those things that can go wrong, because there's a lot of different conditions that can actually show up that we can test for inside of the clinic. And one of the common ones that we see is otosclerosis. So what is otosclerosis for individuals who are first hearing about this term?
So otosclerosis is really where there is a buildup of excess calcium in between the three middle ear bones. And so the way that those middle ear bones work together, they actually kind of work like a pump, like a lever almost. And so they have to have some level of movement between them to do what they need to do. In the otosclerosis condition, excess calcium buildup forms in between those joints. And so now this system that moves really freely with one another in a very specific pattern is completely rigid and stuck together. And when that happens, it's not able to add that additional amplification like we were talking about earlier.
Right, and that would actually require surgical intervention to correct a condition like that. So stapedotomy is done by an actual surgeon, but before that surgeon is actually going to take you through any type of a surgery, they need to know what is actually going on, because they don't want to just go in and do exploratory surgery. They want to have diagnostic tests showing them exactly what they need to go in and do with that particular ear. And this also stands true when you have disarticulation of the ossicles. So those three tiny middle ear bones, the smallest bones in your body, if they have hinges, like you said, they have joints that connect them. And so otosclerosis is when those joints stiffen. Now, disarticulation is when literally those get, those two joints separate, or any of those joints separate from each other. So think if you're in a vehicle accident, this is commonly where this would occur. You get a head trauma, and it actually creates so much force that these bones might disarticulate. So now, when it's trying to send the vibration of sound through the middle ear space, it just stops, like it can't go anywhere else. And then you get that reduction of 26 decibels, like you said, which is huge. But we can actually identify that using the Madsen Zodiac and be able to send that information on to the surgeon, who would potentially go in there and do a treatment for that as well.
Right, and that is why it's so important that we do use this equipment, because these are both two conditions, otosclerosis and disarticulation, that you can't necessarily visualize. So when we use the otocam, like we talked about last episode, from the outside looking in, the ear canal might look very, very normal, but we know that there's something beyond the eardrum at that point that we need to examine, and that's why we're using this specific equipment. However, there are middle ear conditions that we can visualize and that we talked about in the previous episode, but that we're going to talk more about today. And the first one that we'll talk about is a perforation of the eardrum. So as you can see up on the screen there, that is an eardrum that has a pretty large hole in it down there on the bottom. I think earlier you said that looks like the perfect size of a Q-tip.
It looks exactly like the tip of a Q-tip went in there and ruptured that eardrum for sure.
Right. So perforations very generally are unintentional. They are generally acquired through some sort of trauma. So again, could be a motor vehicle accident, but could also be something like an infection. So we have a photograph of this as well. There is a condition called otitis media, and otitis media is a middle ear infection. And so think of small children who have those ear infections and they're constantly going back to the doctors for those. When you have a middle ear infection like that, there is a bunch of mucus and drainage that has filled into that tympanic cavity that we were talking about earlier. causing a ton of irritation. So you can see all of that vascularization, the eardrum's super red, super angry, and you can see that behind the eardrum, it is full to the brim with just some icky drainage.
I mean, and it looks white, and typically a healthy eardrum will be translucent, where it's almost like a window that you can peer through into that middle ear space. But as you can see here, it's super opaque, super white color on that. And this would ultimately typically lead to having a pressure equalization tube, or PE tube, inserted into the eardrum so it can relieve the pressure, first of all, but also drain out that fluid. So there on the screen, you can see a pressure equalization tube in there, and all of a sudden you can tell that all the white has gone away because that fluid has been drained out. In fact, when they do this insertion of a PE tube, they actually go in and they puncture the eardrum. They put a little numbing solution on it, and they puncture the eardrum, and a lot of that fluid will start just leaking right out because it can't escape through the eustachian tube, because the eustachian tube is plugged up. And so they'll go in, they'll suction out as much of that fluid as they possibly can. They have that pressure equalization tube that will equalize the pressure of the middle ear space and allow the space to heal, which is the big thing with that particular type of condition. But the next one that we have here, I think is really cool. I was a second-year graduate student in an ENT clinic when I first in person saw a retracted eardrum, which is what we're going to show you guys right now. It's almost like the eardrum has been vacuum sealed into the middle ear space and covering up those middle ear bones. You can see the head of the malleus there, which is the portion here at the top, which I'll put an arrow overlay over here for you guys. But that right there is the only thing preventing that eardrum from being completely sucked back in to that middle ear cavity in there. And it's just really gnarly to look at, if you ask me.
Right, yeah. Early stages of an audiology program, I think I would have looked in that ear and I would have assumed that they didn't even have an eardrum, or they had a super large perforation, because when you looked in there, I mean, all of the normal typical structures and things that you're looking for, a nice translucent eardrum, that reflection of light, things like that, I would have looked in there and gone, ooh, I don't really know what's going on in here. And sometimes when the eardrum is retracted that far back and looks like that, you don't really know, right? You're assuming, okay, maybe there is a perforation, and maybe up there on the corner that is a hole, but you're not exactly sure. And this is exactly where tympanometry comes into play, because we can determine if there is a hole and prove it immediately, and we don't have to just rely on what we're seeing visually. We can confirm it.
Absolutely, and that's really where the Madsen Zodiac comes into play for us. We have one here on the table, but we also have an overlay here for you guys. And there's a couple of different things that this thing can do. In fact, there's more than a couple. There's a lot of different tests that can be run with this piece of equipment. We're going to focus on tympanometry and reflexes today, because those are two of the more common tests that you would have done in your hearing loss treatment journey. So let's go ahead and get into tympanometry and what the goal of it is. So we really, when you visualize inside the ear canal, you might think that you identify something, but you can never be 100% sure, and you always want to get a recheck. You always want to make sure that what I'm looking at is actually what's happening inside of the ear. And like you mentioned earlier, sometimes we can't tell what's going on behind the eardrum because we can't always see everything behind the eardrum of what's going on. So this allows us to understand the status of the eardrum. It allows us to determine how mobile the eardrum is and how much pressure is in the middle ear space, and we can also identify what the ear canal volume of an individual is as well. Now, we're going to show you an image of us actually performing tympanometry here. Actually, we have a video of us performing tympanometry.
Right.
And I'll let you go ahead and explain that.
Yeah, so it's actually right about to loop back over again right about here. There we go. So you can see I am placing the probe in Kelsey's ear and running the tympanometry test. It's super quick, and you can see over on the screen we've got our results there, and we're going to jump into kind of what those different peaks mean. But the test is really, really fast. I'm talking it's about a 3-4 second test, so long as you can get a good seal. Right?
Yeah, and when we look at it on the screen of us running, I think we're going to be running a right ear on this really quick run. I mean, it takes a few seconds for this to happen. You know, that's you inserting the probe tip into the ear. If you count, I mean, it's no more than 2 or 3 seconds, and that is literally how quick it goes.
That's
right
how
there.
fast it goes. Yeah. So
and we're going to loop that a couple of times here for you, but I mean, we're not speeding that up. That is like in real time. So it's a very easy test to administer as long as you can get a good seal around the ear canal.
What do you tell patients that it's going to feel like when that test is being run?
Yeah, I feel like it's kind of like a very mild sensation of maybe going up and down in an ear plane. It's typically very comfortable. A lot of people are like, wait, that's it? But it tells us so much information. The thing is that it's quick, but it's so valuable to us when we're in the clinic and testing out different conditions.
Hugely valuable. So going back to those peaks that we just saw on the previous screens, there are all different types of tympanograms, and that's what we refer to them as, tympanograms. And there are really 3 primary forms of tympanograms that you can get, and there's 5 if you want to get really
and I do like
it.
to get very specific with it. So let's
then.
get them up on the screen here. Now, I'm going to earn my paycheck right now because trying to explain exactly what all of these are to someone who has no context for this can be a little difficult, but trust me, we're going to get into examples of all of these. So the most normal type that you would see is the type A, where you have that peak right at around the 0 pressure line right there, and it has a good amount of compliance, meaning a good amount of movement to the eardrum. Type B is more of a flat tympanogram. That can be significant of other things that we'll show you here. We do not typically want to see something like that if we can help it. Type C also is showing more of a negative pressure there, and there's a variety of conditions that can cause that. Then at the very bottom of the screen, you have the type AS, which is more of just a shallow tympanogram that we ran on someone, or that you would run on someone. It still has a peak at around 0 pressure, which is good, but you can see that peak is not very high. And then to the right-hand side on the bottom, you have the type AD, which is considered a deep tympanogram. So I actually have one of these in my left ear where the pressure is right around 0, which is a good thing, but there is so much movement to the eardrum that it actually goes off the scale there, and you can't even see the tip of the peak of that particular type of tympanogram. Now, trust me, I understand that probably makes very little contextual sense to anyone watching the video right now, but you're going to start seeing those types of tympanograms creeping back in when we actually show you specific conditions later in this video, which I think is really cool, and I think it's very eye-opening to someone who may have one of these conditions.
Definitely. So really what we're doing with tympanometry is we're assessing 3 specific variables here. Number 1, what is the status of the pressure in the ear? And so you'll hear us say again and again, negative pressure, negative pressure. Negative pressure is really just that retracted eardrum that we saw. We're going to look at it again here in a moment. But really, we'd like to keep that pressure as neutral as possible. The main goal of the eustachian tube in your ear is to keep the pressure in the outside world and the pressure inside the tympanic cavity at the exact same level with one another. So when you yawn and your ears pop, that's that eustachian tube actually opening and closing to equalize that pressure. And that actually happens naturally between 200 and 300 times a day with speaking, swallowing, yawning, things like that. So there are several different conditions that can impact the eustachian tube and mess with that pressure, and that's what we need to see through tympanometry. Compliance is another one that we're looking at, and that is just how much is it moving, and then ear canal volume, and that's a really, really important variable that we're looking at. Ear canal volume is telling us really if there's a perforation in the ear. So we'll talk about that here in just a moment.
Perfect. So yeah, we're going to take a look and see how Natus's Madsen Zodiac Tympanometer is going to help us assess these things. So let's go ahead. We're going to look at a type A tympanogram, and we're going to look at it for a normal ear. And so when we were running Kelsey originally through that video, we were identifying that she had completely normal tympanogram for her, so type A. And so this right here is when we're looking into an ear canal, everything looks totally fine for us. If there's some kind of reporting that a patient would give us of being like, yeah, I just feel like plugged up in my ear or something like that, and we look at this, we're like, we should probably run a tympanogram so we can see if there is actually something going on behind the eardrum that we cannot visually see here. And we can actually look at what the tymps would be for this particular eardrum. And when I say tymps, that's just short for tympanogram. And so what we're looking at right here, blue is the left ear, red is the right ear. That line, vertical line that you're looking at right there, both of those peaks line up pretty closely right around the 0 pressure mark, which means that there's equal pressure from the outer ear to the middle ear, which is exactly what we want to have happen. And like Dr. Cook, you were saying, is that when you chew on food, when you swallow, when you yawn, things like that, the eustachian tube is opening and closing, allowing that pressure to always be equal if you have a healthy middle ear space.
Right. And I think you made an important point there that we're doing a lot of talk about best practices here, and it's important for us to note that this test, tympanometry, is not always going to be done on you as a patient, particularly if you are not expressing any concerns with pressure, any fullness. Potentially you would be put through the hearing test, and if the test indicated that there was potentially a mismatch pointing to an issue in the middle ear space, maybe then the provider would go back and do tympanometry after the fact. But I just want to make it very, very clear that just because this test is not done on you does not mean that best practices are not being followed. Tympanometry does need to be done on you if you are expressing one of these conditions or one of these symptoms, but it's not going to be done on everybody.
Yeah, and we typically are looking for, if we're going to be doing a hearing test on someone, we're looking for what we call an air bone gap, which indicates potentially a conductive component or a conductive hearing loss, which is where there's something impeding the flow of sound through this system that we're talking about. So the outer ear, which we talked about in last episode, and the middle ear of what we're talking about in today's episode. So if we see a discrepancy during the standard, listening for the beeps and raising your hand or clicking a button, that would be like okay, we need to actually run tympanometry because there's something else going on that we want a little bit more information about.
Right. So the next one that we're going to look at is going to be back to that otitis media, or that really infected, inflamed eardrum there. So again, another picture of that. You can see that that middle ear space is full to the brim with infected fluid. And this is really going to cause one of those type B flat tympanograms, but there's another type of condition that can also cause a type B flat tympanogram, and that's going to be that perforation. So this is where things get a little bit tricky with type B tympanograms, because from someone who's watching this video that doesn't have a ton of experience in this field, they might be like, how the heck are those two tympanograms the same type of tympanogram? And this is really where the ear canal volume measurement is coming into play. So we have a picture of what these different tympanogram results would look like. Up at the top there, you can see that that is a very flat line, a type B tympanogram, but that the ear canal volume is really, really large, 5.2 right there. And that tells us that we are not only taking a recording of the outer ear canal space, but we are now also taking a volume measurement for the middle ear space. So much larger recording than we're used to. That one on the bottom, you can see that the ear canal volume is very, very normal, which is good, except for the fact that we have zero compliance from the eardrum. And so that tells us that the eardrum is intact. There is no hole, there is no perforation, but there is no movement because it's stuck.
That's right. So either so really what's happening here is that air is getting pushed into the ear canal from the probe tip that we put inside of the ear, and then it's retracting that air back out, and it's measuring how much it was able to push in the eardrum, how much it was able to pull out the eardrum. And if you have fluid, like you saw there with otitis media, basically air is getting pushed in, and that eardrum's like, nope, I'm not moving anywhere.
Yep.
I'm just staying still. So it ends up giving us a flat line on that with no peak because there's no movement. Of course, if you have an open hole there, basically the air's just passing straight through that opening, coming right back out, and the eardrum doesn't move at all.
Yep.
So you literally get a flat line with both of them, but the telltale sign, like you said, is the ear canal volume. The ear canal for an adult is typically going to be close to 1, maybe 1.5 on that measurement that we looked there. So when you have a measurement that's like 5 or 6 or 7, it tells you that you're actually measuring the entire middle ear cavity, which is substantially larger than just the ear canal itself. So if you actually run a measurement on someone, this is something that's interesting. You might look inside of their ear canal and be like, hey, that looks like a normal eardrum. And then all of a sudden you get a flat response with a big ear canal volume, and you're like, huh. They have a hole in their eardrum that I was not able to actually visualize.
Yeah.
And that can have a negative effect on the hearing test. So you see how all of this stuff starts piecing itself together? Once you have more of this data to work with, you can make a better diagnosis of what's going on with a particular patient, and then you can get them referred to the proper professional to get that addressed.
Right. All of these things come together to really give us the next steps and what we need to do from there. So we have a third one, and this is one that totally we talked about earlier. really needing a tympanogram on this person to determine whether or not there was a perforation. So we've got that a graphic of that retracted eardrum again up on the screen. See, if I were to look straight in there, I would not know if any of those retraction pockets, I mean, I guess you got a good reflection from most of them in this picture, but it doesn't always present that way. And there have been very many ears that I've looked into and gone, I'm not exactly sure if there's a perforation here or not. Because again, we're working with an extremely small space. I bet the eardrum in most ears is probably the diameter of what, a dime, a penny?
Yeah, a dime, maybe even smaller than a dime.
It's really
yeah,
small.
Mine's probably bigger than a dime. I have huge eardrums. I don't know why. Fun fact about Dr. Cliff, I guess.
I guess so. And the perforations, it doesn't really matter the size of the perforation because it can still result in hearing loss. Even a pinhole perforation can still result in a conductive hearing loss, and it can still result in having a flat type B tympanogram as well. So in this case, we have a picture of the results for what the tympanogram would have looked like on that ear. And you can see that on this one, you've got that peak that you're looking for, and it doesn't look flat. So we know that there's not a perforation. We know that the eardrum is intact. However, the pressure in that ear is extremely negative. So that eardrum is just being sucked completely backwards into the middle ear space. That really stiffens the system overall, meaning that that movement of the middle ear bones that we were talking about earlier is really compromised by that stiffness. And now you have a conductive hearing loss because of that. So that's going to result in that clogged, full pressure type of sensation in the ears, and you're going to yawn and yawn and yawn and beg for your ears to pop. And for this person or this individual, they were not popping. They were just staying like that.
Yeah, and sometimes you can get it to pop, and then having a eustachian tube dysfunction just makes that negative pressure return back because it will not allow for the equalization of pressure consistently inside of that ear. And so there are other reasons that you might even see a peak like that. It could be for, going into or coming out of a middle ear infection as well. But, there are ways that you can, plug your nose and blow, the Valsalva maneuver. You have the Lowry method that you can use to try to equalize that pressure on your own. And sometimes we use this to identify, okay, is this just an absence of sound that's making you feel like you're underwater? Or is it literally that you're running a negative pressure like that and you need to do something to try to equalize that pressure?
Equalize that pressure, for sure. Yeah, and earlier we talked about doing like a PE tube for, in the case of otitis media, when you have this infection and the drainage needs to come out. But there are very many adults that struggle with eustachian tube dysfunction. I saw this at the ENT clinic over and over and over, that actually do get pressure equalization tubes put into their ear as well, not because they're having ear infections, but simply because they cannot equalize that pressure. It's a very uncomfortable feeling, so they put in a pressure equalization tube to allow for that transfer of airflow and equal pressure, and just kind of leave the eustachian tube out of it at that point.
For sure. The ear canal is a very sensitive area because it's skin, that lines that ear canal. And when you have the annular ligament, which actually attaches the eardrum to the skin of the ear canal wall, and you start retracting that in so forcefully because of a negative pressure, that can cause a lot of pain.
Super painful.
So it can cause a lot of pain. It can cause hearing loss. It can cause a variety of different things that you do not want to be feeling at that time. And so it's really good to get it actually identified, determine what is actually causing this, and then go and receive the proper treatment for it. Sometimes it's not a big deal. They're like, oh, I didn't even know. Like, everything feels normal to me, but I have a hearing loss that's being caused by this negative pressure inside the middle ear that needs to be addressed.
Right. Now we've got a final video here, and I really like this one. So I took this one personally in clinic, and this particular patient did experience, he was using Q-tips, and he had put one in, and he thought it went a little too far, and he felt a little bump. And then we looked in his ear, and this is what we saw. This video was some movement of the eardrum there. Now, looking in, I had presumed that I was going to see a perforation because of what he had expressed. But then we saw this, and as you can see with the movement there, that told me, okay, more than likely it has healed up entirely, right? And again, this is one of those situations where you have no real way of knowing just by visualizing. At this point, we need to take it a step further, and we need to run tympanometry to see. And so for this particular patient, I actually wasn't able to get a seal on the tympanometer, and you need a really good solid seal for it to take all of those measurements of compliance and pressure and volume. And when you don't get a good seal, it can mean a couple of things. You might have just a really strange kind of shape of your ear canal that's making it tough, or you have a perforation. And in this case, I think there's actually a couple of different things going on where he did, in fact, have a perforation. And on top of that, he also had a eustachian tube that was a little too open, and it stayed open all of the time. So your eustachian tube is really supposed to be opening and closing at specific times to equalize pressure. Well, that movement that you could see, that was with his breath. So when he'd breathe in and breathe out, you can see his breath affecting that eardrum mobility. That tells us that the eustachian tube is staying open full time, and now your breath movements are changing your eardrum positioning. So
absolutely. And the other thing that I know that we referenced that in last week's video too, but if we bring that graphic back up on the screen of that video, the thing that I found to be interesting is right where you can see the movement of the eardrum, there's a little patch of white right there.
Yep.
That right there is scar tissue on the eardrum. Now, individuals who've had ear infections growing up or who've had a lot of trauma caused to their eardrum, I know that some divers have issues with their eardrums. You start building up a lot of that scar tissue on the eardrum, and all of a sudden you start getting more of a shallow measurement with the tympanometry. And that can again let you know, okay, is the flow of sound going to be impeded on this pathway from the outer ear through the middle ear, because that the vibration of the eardrum is affected by all of that scar tissue.
Yeah.
And so these are all those things that you start piecing all of this information together. So if we start identifying certain things either through visualization with the Otocam 300 from Natus, and we start identifying that there's hearing loss that doesn't make a whole lot of sense based on the reporting that someone is giving to us or based off of just what we're seeing in the hearing test, it really means we need to take that next step, following best practices and doing these additional tests.
Yeah, we do a lot of investigation. We take a lot of puzzle pieces and put them together throughout this entire patient journey. Your own personal journey isn't always going to be the same exact steps that we're following on this series, but each of these steps is really integral in coming up with a good, solid diagnosis and then moving on to treatment from there.
For sure. Now, if you can get a good seal with the probe tip, that allows us to do an additional test that we want to talk about today, which is probably the second most common thing that you would use the Madsen Zodiac for, which is reflexes. So we can actually measure reflexes inside of your middle ear space. So I want you to think of this. When you go to the doctor and they're testing your reflexes on your knee, they'll take that little rubber mallet, they'll tap you on the knee, and then if your knee's working right, you know, if the reflexes are working right, your knee will, or your leg will kind of shoot up as a reflex. Like, you have no control of it. If they tap it, your knee's going to go up when they tap on that. And so it's a very similar function that we have inside of the middle ear space, because we have the stapedius muscle that has a reflex to it. So if we put certain sounds, different intensity of sounds into the ear, we expect to get a reflex of that particular muscle, and we get to measure that using the Zodiac, which is really cool.
Right. Now, this muscle reflex is really important to, I think that the goal of it, or the reason why we have these reflexes, is in response to loud sounds that could potentially damage your hearing. And so what the stapedius muscle, when it does, is when it contracts like that, it is stiffening the rest of the system and the middle ear bones to try to make sure that that 26 decibels of amplification that's normally added on by the system operating as usual is not being added on top of an already super loud sound that can potentially damage your hearing. So when we are checking out these reflexes, we're really just making sure that these reflexes have integrity to them and are able to perform that function.
For sure. And, you know, we talk about best practices a lot on our show, for sure. It isn't necessarily required that this particular test is done. It is really dependent on everything else that we're identifying from a patient throughout this journey that they're going through with us. But when the situation calls for it, this test can give us a little bit more information as to what's going on in the neural pathway there. Because when you think about how a reflex works, when you stimulate something, it either goes all the way to the brain or it has to travel through the nerve to send a reflex reaction back out to cause that stiffening of the stapedius muscle. And so we can test a couple of different pathways with this, both a pathway that's crossing over through to the other ear and a pathway that stays inside of the same ear. And so that's really what we're testing to identify if this reflex is working the right way. And so we actually have a video of these reflexes running, which I think is really important for for us to all understand here. So if I try to explain it as we're running through these measures here, at the very top of this measurement on the Madsen Zodiac, you can see that we're presenting at different decibel levels. It goes from 80 decibels to 85 to 90 right there. It'll end up going to 95 and then even into 100. And when you look down at the 0, line down here, if you have a flat response, that means when we're putting in that decibel level of sound, it is not giving you a reflex. And then once you start getting to around 90, 95 decibels, now we're starting to see a reflex reaction happening with this particular measurement.
Right, and we're completing these measurements at distinct frequency ranges, and what this actually gives us is kind of a estimate of your own hearing sensitivity as well. So kind of a little insight into what your hearing test may end up looking like, because like you said, that sound does have to go through the entire system all the way up to the brain for it to determine that the sound is loud enough to elicit this response. So if you have enough hearing loss in a particular frequency range to where the brain doesn't register that sound as being super loud, then you're going to see those flat responses like you saw at the beginning. But what we're really looking for on these reflexes is a pretty good amount of movement. I believe between 0.02 and 0.04 is kind of more of the significant range there. But what we'd like to see is that little dip down and then come back up. And that tells us that at that frequency range and at that decibel level, we had a true reflex.
That's
there.
absolutely right. And I don't want to be an alarmist with this, but if we start presenting sounds at a sensation level that we know that is being heard by you, because we took you through a hearing test, and we're like, okay, well, based on your hearing loss thresholds or your hearing thresholds, we've identified that we're presenting a tone here that should be eliciting a reflex. And if we don't get that reflex, it makes us go, is there something that's impeding the flow of this, not in the middle ear space, but throughout the neural pathway?
Yeah.
And so once we start getting a lot of absent responses to where we're like, man, we tested at 500 hertz, 1,000, 2,000, 4,000, and we're not getting reflexes here, that could indicate a serious medical condition, which we need to refer out to an ear, nose, and throat physician, and likely that ends up resulting in getting an MRI because there might be something like a tumor or a growth happening on your auditory nerve or at some part along that neural pathway.
Right. So there's very, very specific configurations that an audiologist is looking for when taking into account what your outer ear looked like, what your tympanometry measure looked like, and what your hearing test looked like, and then coming back to the reflexes. There are very many times when you can have absent reflexes that do not indicate anything more serious or anything more sinister going on. However, if one of those puzzle pieces is not lining up with the absence of the reflexes, then yeah, we definitely need to look into that much deeper.
For sure, and I like the reference to the puzzle pieces because that is exactly what is happening throughout this entire hearing loss journey, is that we are just filling in piece after piece. And we're still early on. We're still in the first visit of someone inside of the clinic, and we're running all of these tests to help us identify what is actually going on. And the more specific we can be with that diagnosis, the better we're going to be when it comes down to treatment recommendation or referral out to see another professional as well.
Right.
And so there's a lot of other tests that can actually be run with the Zodiac as well. We're not limited to just those two things. But again, this is one of those, are we filling in another puzzle piece that would be useful for the diagnosis of something or to actually refer out? And then the other fun thing when you're using this particular equipment from Natus is that you get to see it all inside of the exact same place.
Yeah.
And so you might be doing testing in the sound booth with all of this stuff, and then you go back into the consultation room with your doctor, and they're running through all of this information. And if you've had issues in the past with your middle ear space or your stapedius reflex or your eardrum, whatever, they can reference previous test results and give you that A-B comparison so you can actually visualize it and understand it better as a patient.
Yeah, for sure. From a counseling aspect, yes. So next episode, for sure, we're going to do a deep dive into Otosuite, which is an offering from Natus as well, that's going to take the information from all of these assessments that we're running in the clinic and have them all in one place. So like you said, past, present, and even moving forward into the future, we are able to reference exactly what your ear canal looked like, exactly what your middle ear pressure and compliance looked like, potentially what your reflexes looked like at the time, what your hearing test results look like. All of these puzzle pieces, really you can think of Otosuite as kind of the puzzle board or the table that you're putting all the puzzle pieces on. and being able to go back to all of those as well.
You know, I want to reference time that we spent throughout our education. I know that the clinic that I came up in did not have advanced diagnostic equipment. It's like that equipment was like, man, was that from the 1950s, the equipment that we're actually using right now?
Oh, yeah.
And I can tell you that using equipment that is more high-tech, that is all integrated together, has made me be a better audiologist, because I think a big role of an excellent audiologist is being able to clearly articulate what the test results are to a patient in a way that they can understand it. And when you start, you look at some of the old equipment, and I'm not going to name names here, but there's equipment that's out there that you literally have to print off the measurement on a strip of like a carbon paper. It's like receipt paper. And then you go in and you're trying to explain what that is to a patient, and it's all like black and white, and there's no color reference for left and right ear. It's very hard to read.
It never prints right. And just you get like, I used to get like the streaks all down it and everything, and you know, how awful is it to turn it around to a patient and be like, okay, so this is the, it's like, it just looked like you picked up a receipt off of the sidewalk. Like it just made a whole lot of no sense at all.
And you know, and I don't mind going to a doctor if they're doing things that are of value and I'm there for a long time. I'm totally cool with it. But what I hate is just like sitting around twiddling my thumbs, waiting for them to print out results of something and come into the room and barely explain it to me. Like, I want to make sure that my time as a patient, if I'm the patient, that time is being spent very valuably. I just don't want to be sitting around inside of the clinic. And so having higher tech equipment that can run through these tests, you see how quickly some of those tests can be done, but you don't want to wait an additional 15 minutes to get those results to you and explain to you. I want them like right now, because I'm impatient.
Yeah, well, and having them all in that one singular place is just so huge, because I can't be running through, you know, if a patient comes to me 6 months after I had seen them for a particular condition or something was going on, I can't be going back through each individual scanning of a document and in their file and trying to find, oh, was it this tympanometry test that we ran or this one? And what did your ear canal look like that day? Was there anything going on? I mean, OtoSuite, it really allows us to have all of those pieces right in front of us, dates, times, and I can flash back to any of them within any given session. So you're exactly right. It has made my experience as an audiologist, I do feel like a better audiologist having up-to-date modern equipment that's just, gosh, it just works so good.
Absolutely, absolutely. So let's go over and rediscuss here. So the goal of running tympanometry and reflexes and all the other tests that you can do with the Madsen Zodiac here. So we really want to make sure that we're assessing the middle ear with this, and we can even assess some part of the outer ear with this as well, with the ear canal volume. But it ensures that our eardrums are intact. It determines the mobility and pressure status of the ear, the middle ear space itself as well. And then you can test those acoustic reflexes to determine the site of lesion. And when we say site of lesion, it means that we're trying to whittle down to what is the actual cause of the problem here, so we can get a patient referred out correctly or just treated correctly inside of the clinic. And then it acts as an important cross-check as well. And I don't think that we stress that enough, is that sometimes you can't make an accurate diagnosis when you're only looking at one piece of information. So having multiple pieces of information really helps us out when we're trying to do our job better.
Most definitely. And then that final piece of that is just determining if an ear, nose, and throat referral is needed. And so a lot of these conditions that we have spoke about today do require seeing an ear, nose, and throat physician to have them diagnosed and then treated from there. But then chances are, even if they are treated, a lot of times these cannot be treated entirely, or you may still have some residual hearing loss after the fact of treatment, and that just gets you right back to our office again to talk about how are we going to remedy that situation.
That's right, and then essentially running these tests on them after they've received treatment to see, okay, did the problem actually get corrected, and to what degree it got corrected, because that can change the way that we actually administer treatment when they inevitably come back into our clinic for that follow-up treatment. So. All right, guys, so let's go ahead and talk about what we've discussed so far in this series, and then getting into what we're going to be talking about in the next episode. So last week we talked more about the outer ear. Today, obviously, we're talking more about the middle ear and that pathway of sound. And when we come up into next week, we're going to be talking about the inner ear and how we do an audiologic evaluation after we've completed assessment of the outer ear and middle ear in this hearing loss treatment journey. And we're going to be talking about the too. And then like you had talked about earlier, we're going to be getting into the Oto suite that kind of ties all of this information together, so it is very easy for someone who's going through all of these tests to actually understand, even if you do not have a degree in audiology. So make sure that you are tuning in to this bonus series that we are doing about the hearing loss treatment journey. If you have not hit that like button yet, go ahead and do that, because that really helps us out. And if you want to make sure that you don't miss any of these future episodes that we're putting out, make sure that you hit that subscribe button with notification bell as well. And as always, we'll see you next week.